Heather, the stage is yours.
Excellent. Right on time. Good afternoon, everyone. I'm Heather Ciccarelli. I'm the Director of the Patient Navigation Initiative here at the American Cancer Society, and I am delighted to welcome you to session 3, the final session of our first webinar series. We kicked the series off on June 5th with a very inspirational speaker, Dr. Rob Wynn. We had an informative session last week with Dr. Shanita Hughes-Halbert from the University of Southern California and Dr. Mary Salazar from the University of Texas, San Antonio. And we have 2 terrific speakers for you today. And on behalf of the American Cancer Society, I am proud to welcome you today. This webinar will be recorded, and we will be sharing the recording at the end of this week. We are not able to open the microphones live today, but if you have any questions, please answer them. Please place them in the question and answer box, and we'll do our best to answer any questions at the end of the session today. And we plan to add an extra session in the fall to bring all our panelists back to get have some lively discussion, since we have not had ample time to make sure that we are able to answer everyone's questions. And we've had so many great questions come in. I'd like to take a moment and give special thanks to our sponsors who support our work. Sponsorship for this initiative was led by AstraZeneca and the Janssen Pharmaceutical Companies of Johnson & Johnson, along with Bristol Myers Squibb. Additional sponsors include GlaxoSmithKline, Daiichi Sankyo, Novocure, Pfizer, Santa Fe, and other sponsors. This webinar today will be moderated by Linda Fleischer. She is the co-chair or vice co-chair of the National Navigation Roundtable. And I'm delighted to introduce her today. Dr. Fleischer is a research professor at Fox Chase Cancer Center in Philadelphia, Pennsylvania. As I said, she's the vice chair of the American Cancer Society National Navigation Roundtable and serves on the Evidence-Based Task Group. Dr. Fleischer has been involved in patient education and navigation for over 30 years, directing one of the regional offices of the NCI's Cancer Information Service, establishing the Fox Chase Cancer Center Resource Education Center, the Pennsylvania Patient Navigation Demonstration Project, and other research projects integrating patient navigation. I'm delighted to turn this over to Linda, who will introduce our first speaker and guide you through today's session.
Oh, thanks so much, Heather. It's really such a pleasure to be here. And both Andy Dwyer, the chair of the NNRT, and I have been moderating these sessions, and they've just been fantastic. And we're so delighted for today's session as well to kind of dive deep, right? And really in terms of how to do this type of navigation in the clinical trials space. And so I will be checking questions as we go along, and hopefully we'll have an opportunity to ask at least one question, Marisha, at the end of your presentation. If not, we'll take them at the end. So again, I will be monitoring questions, and please, if you have questions, comments, things you want us to talk about, please put them in the chat so that we can kind of address them. So let me first introduce Marisha Hicks Person. MHA is a department project manager at UT Southwestern Medical Center's Harold C. Simmons Comprehensive Cancer Center. She serves as the bridge between the Clinical Research Office and the Office of Community Outreach, Engagement, and Equity. Quite a job being that bridge, I'm sure. And she's responsible for the development, implementation, and management of programs and initiatives that address diversity and equity in clinical trials. She is passionate about health justice and serves on the Cancer Alliance of Texas Disparities Work Group, as well as Longevity's Financial Neutrality Best Practices Work Group. Mrs. Person has a Bachelor of Science in Business Administration from Fisk University and a Master's of Health Administration from Virginia Commonwealth University. She's a member of the American College of Healthcare Executives, and within UT Southwestern Medical Center has served as co-chair of the Women and Allies Business Resources Group and committee member of the African American Employee Business Research Group. We are just so delighted to have you, Marisha, and really looking forward to your presentation.
Thank you so much, Dr. Fleischer. Good morning, everyone. Thank you guys for joining this webinar today. See if the slide is advancing. Oh, that went a little bit too far. Okay, so today we want to talk to you a little bit about the Simmons Comprehensive Cancer Center's Clinical Trial Navigation Program. We'll talk about how and why this program was created. We'll share with you some of the best practices that we've implemented, and then later on, Fabian will discuss some of the lessons we've learned along the way. So cancer clinical trials are facing a crisis. As you may or may not know, less than 5% of adult cancer patients actually participate and enroll in cancer clinical trials. This creates an issue because low accrual rates prolong study duration, they limit generalizability, they lead to premature study termination, but they also limit the number of patients who are exposed to these beneficial experimental therapies, and they leave important clinical questions unanswered. However, if general patient participation is the issue for cancer clinical trials, then diverse participation is a significantly larger issue from my perspective. A publication in the ACS journals in 2021 showed that African Americans made up only 3% of cancer clinical trial participation, and Hispanics represented only 6% of participation. This is an issue again because we know that African American patients, Hispanic patients carry a higher burden for cancer incidence and cancer mortality. So they are not receiving the benefit of these patients. The patients who should be receiving the benefits of these clinical trials are not. But also it's important because we are unable to be sure that we are creating drugs and devices and products that aren't harming these populations if we are unable to study them. And the combination of those things lead to increased health disparity. So why is there low representation? There are many barriers to cancer clinical trials, and we've seen this in the literature time and time again. There is unconscious bias. Sometimes providers, unfortunately, look at patients and make assumptions, and they never invite patients to participate. There are plenty of studies out there that show that in a lot of cases, if Black and Brown patients are asked about participating in clinical trials, that they are open to it, but many times they're never asked. We also know that there is mistrust and historical discrimination. This country has a long history of violations against people of color in the name of research. And we remember, right? Communities of color remember. And so that leads to this mistrust that currently exists. But furthermore, I would argue that it's not just historical discrimination, but there is currently discrimination generally in healthcare that is still happening. And so, that mistrust is in the healthcare system, not just in clinical trials. So we have some ground to make up there as far as the healthcare system is concerned, but we also need to make sure that people understand about clinical trials. So mistrust is an issue. Location is also an issue. If you think about patients who are in rural locations who don't have access to centers like UT Southwestern Medical Center, we are this beacon of research and education, but we are located in a particular place. And that doesn't always extend out to rural areas. That doesn't always extend out to the communities that we're hoping to serve. And so location can be a barrier for many patients. Inclusion and exclusion criteria is also a barrier. When researchers develop their research projects, sometimes they will add criteria that is frankly unnecessary for the research. sometimes there are providers that are saying, you know, for this project, we don't want patients who have comorbidities or who have had cancer before. And as we all know, Black and Brown patients tend to also carry a higher burden for chronic illnesses, for comorbidities, for diabetes and heart attack and stroke and COPD, and also, as I mentioned earlier, a higher burden for cancer. So that those exclusion criteria can exclude populations and communities of people. There's a cultural competence and linguistic barrier as well. And this is shows itself in a couple of different ways. One way is if you don't have staff that are able to communicate, to relate to, that look like the patients, that the communities that they serve, that can be a barrier. But also in the materials, the education that is provided, if those documents are not translated into other languages that our patients can understand, you know, we can't get patients on the clinical trials if we're unable to explain to them what the clinical trials are, and educate them about their disease in languages that they understand. And then last but not least, there's cost and other logistical barriers. If there are patients who are unable to take off work to go to UT Southwestern 3 times a week to participate in a clinical trial, if they don't have childcare or senior care or pet care, you know, if they don't have access to transportation, again, these are all barriers to participating in clinical trials. And many times these barriers disproportionately affect communities of color. So let's talk about our cancer burden in the Dallas-Fort Worth area. This is the area that the Simmons Comprehensive Cancer Center serves. And as you can see, looking over to your left, that our catchment area is a majority minority community. 54% of our population that we seek to serve is minority. We have a 29% Hispanic Latino community, 22% of that is Spanish speaking only. We have 16% Black and African American, and 46% is white. And so we have a large community that's very diverse population. And we also rank 50 in the country as Texas, the state, we rank 50 in insurance coverage. So that's unfortunate. We were not a state who expanded Medicaid. We tend to have many communities that are disproportionately affected by this. And so we are 21% uninsured in the DFW. So of course, this creates an issue of access for those communities. So we knew that at UT Southwestern with the Simmons Cancer Center that we are uniquely positioned to address this issue of representation in clinical trials. And this position comes because of our partnership that we have with Parkland Health. Parkland Health is not only UT Southwestern's main teaching facility. So this is where all of our physician trainees are trained at Parkland, but also Parkland is Dallas County's safety net provider. This is the health provider that cares for the patients in our community who are uninsured, underinsured Medicaid. And so again, these patients are disproportionately patients of color. And we know that if we want to affect change and impact these communities, we have to partner. And we have to do this by starting with Parkland. We're also uniquely positioned to do this because UT Southwestern Simmons Comprehensive Cancer Center is a matrix center, and it integrates cancer care, community outreach, cancer control, but also research, not only across UT Southwestern, but with its partners that include Parkland. And so in order to impact this representation in clinical trials, we decided to create a clinical trial navigation program and started with a clinical trial navigator who was facing Parkland. In 2020, Fabian Robles, who you'll hear from a little bit later on, was a Spanish language interpreter at UT Southwestern Medical Center. He was hired as the very first clinical trial navigator, and he faced Parkland patients exclusively. And what he did at that time, with the goal, of course, of increasing interest in clinical trials and removing barriers to participation for communities of color, what he was able to do was really explain the value and importance of clinical trials to these patients. He was able to pre-screen many patients for trial eligibility, but he invited them to participate. Many patients who may not have been invited. He invited them, he answered any questions they may have had. He addressed barriers they may have had, including social determinants of health barriers. He consented and enrolled them to trials. And then after they were already on the trials, he followed up with those patients and made sure that they didn't have any new barriers that presented while they were on the trial. In addition to the work that he did with the patients, he also educated the providers about what clinical trials were open and accruing and that they might be able to refer into. So his role had two parts, right? One on the patient side and one on the provider side. But with the work that he was able to do, Parkland enrollment increased by 110% over 2 years. And so it's because of that that we knew we needed to expand this program. And fortunately, we received support from several organizations that allowed us to do so. We received funding from the American Cancer Society with a grant specifically aimed at capacity building for patient navigation. We received an award from the Cancer Prevention and Research Institute of Texas that was specifically aimed at increasing diversity in clinical trials. A Stand Up to Cancer grant that's specifically aimed at increasing diversity in early phase clinical trials. And then we also had institutional support as well for this clinical trial navigation program. So what does that look like? Oh. I think these are the wrong slides. So what does that look like? We have the clinical trial navigation program as the overall umbrella that is supported by the American Cancer Society. And that program simply exists to educate the patients as well as the community about clinical trials. We invite patients to participate. We answer their questions. We provide resources. We maybe refer them to other support services if need be to assist them with their care. But we also address barriers to care. We have the Clinical Trial Financial Reimbursement Program. This is the program that's funded by the Cancer Prevention Research Institute of Texas. And it serves to reimburse patients for non-clinical costs that's associated with their clinical trial participation. So we not only reimburse patients for travel and lodging, but we also reimburse them for meals, for childcare, and for Wi-Fi, which we know that there's an access issue for in the Dallas community. And then we have our Stand Up to Cancer Award, which is enhancing access to early phase clinical trials. As you may or may not know, early phase clinical trials typically have routine care costs that are not funded by the sponsor. They are funded by a patient's insurance. Well, if a patient is uninsured or underinsured, then they don't have access to participate in these types of trials. What we're doing at UT Southwestern is, again, in partnership with Parkland, we are navigating patients from Parkland to UT Southwestern to participate. And those routine care costs are partially funded by Stand Up to Cancer, and then they are partially funded by the Simmons Cancer Center. And so it's through these initiatives that we are removing barriers to care. We are removing the unconscious bias because our clinical trial navigators are asking the question. We're inviting them to participate. We're removing mistrust by educating our community and our patients. We're removing the location barrier and the cost and logistics barrier by reimbursing patients for those non-clinical costs associated with their trial participation, and removing the cultural and language barrier by making sure that our staff are culturally sensitive and mirror our community, and that the materials that we provide to them are appropriately translated. Through these things, we increase diversity, we provide equitable access to clinical trials, we give hope to patients, and we provide better outcomes. So what are the best practices that we implemented? Well, as you can see, these are our clinical trial navigators. Through all of the amazing work that Fabian Robles was able to accomplish, of course, we promoted him to manager of clinical trial navigation. We hired Marisol Rojas, who is also a Spanish language interpreter, and she now serves in the role at Parkland that Fabian began in 2020. And then we also expanded the clinical trials navigation program into UT Southwestern. When we started, it was just facing Parkland. Now we have D'Angelo Grant, who is facing our patients at UT Southwestern and expanding that program that way. Our navigators are educated, not only generally in patient navigation, but we also make sure they receive extensive training in why it's important to have inclusion and equity in clinical trials. This training that you see in front of you is actually one that was developed in our Semin Cancer Center Equity in Clinical Trials work group, which is a work group that we have that specifically exists to address the issue of equity in clinical trials and think of initiatives and programs to support it. They developed this training, and this training is now required for all clinical research staff and also all faculty. And so I have this slide, it is staff education, but also institutional support, because we talk a lot when we think about institutional support, we think about funding initially, but it's also really important to have the buy-in and for the institution to know how important it is. And so the fact that this training is now required for our staff and our faculty is huge, and that requires institutional buy-in. Community engagement is also extremely important. The picture that you see to the left actually is a very recent picture. This was a Juneteenth event that happened that we attended, and we had a booth there. And as you can see, we have fun. We have lots of swag for our community. We play Cancer Jeopardy to educate them about breast cancer and prostate cancer. But we also have information at these booths about clinical trial participation. And at these booths, I spent a lot of time speaking to the community and different individuals about what clinical trials are and what their ideas around clinical trials are. What are their attitudes? What have they heard? What do they know, right? And telling them, you know, how important it is to be educated and to understand what they really are. To your right, you see diversity in clinical trials, representation matters. This is a presentation that I've given throughout the community at various organizations and cancer support groups. And again, it just really talks about why it's important for there to be diversity in clinical trials and why representation matters. It's also very important to have linguistically appropriate education resources. The document to your far left is a document that talks about the clinical trial financial reimbursement program. It tells patients what services are offered, what things can be reimbursed for, what the requirements for the program are. And as you can see, we have that in Spanish. We also give patients a frequently asked questions document on cancer clinical trials and information they should know. All of these documents we have available in English, Spanish, Vietnamese, and Arabic. And so the best practices that we were able to implement with this program were first and foremost institutional support. Again, as I mentioned before, funding is important, but it's also important to have institutional buy-in and for them to understand the importance of a program such as this. A diverse workforce is very important for our navigators to mirror our community. It's important for patients to see themselves in the navigators, to gain trust and to build relationship. Clinical trial education, it's important that we talk to patients about what clinical trials are and what they are not. I always say, you know, it's not that we're trying to encourage patients one way or the other. But what we want to do is we want to educate them enough so that when they're making a decision about clinical trials, it's from a place of information and understanding and not from a place of fear. This clinical trial education also refers to what the navigators are doing with the providers and informing them of what clinical trials are available and accruing, and also refers to the education that happens with our clinical research staff and faculty in understanding the importance of diversity in clinical trials. Culturally and linguistically tailored information, of course, is very important. Patients have to understand what it is that they're getting into. They have to feel comfortable and feel like they are being respected culturally, and that they're able to really understand what clinical trials are and how they work. Community outreach is important. It's important to get out there before patients come in. I mean, of course, we want to educate patients when they come into the cancer center. It's very important for them to understand clinical trials at that point, but it's also very important that we reach people before they present to a cancer center. It's important that patients have an idea and it's demystified, right? So again, those decisions are not being made out of fear, but out of information. And then, of course, financial and logistical support. We have to remove barriers, and sometimes those barriers are financial. Sometimes patients want to participate and need to participate, but can't see a way around it. They don't have someone to care for their loved ones. They can't afford to take off of work. And so it's important that we understand that, particularly with communities of color, these types of things affect them, and we have to provide support in those areas. And so thank you so much. You will hear next from Fabian Robles, who will talk to you a little bit more about the specific things that we did to implement this program and the lessons that we learned along the way. Thank you.
Marisha, that was fabulous. And to kind of hear this very comprehensive, right, approach, it's not just at the point of a clinical trial, but all of these other elements that are so critical to success. I think we have time for one question, and there was a question in the chat, so I'd like to pose that to you before I introduce Fabian. So one of our participants said one of the questions, she recently learned that some providers may feel hesitant to suggest a clinical trial after trust has already been established with the patient, in fear of losing that trust. And I think you mentioned something earlier on about often people aren't asked. And so what advice might you give to say, to help our providers understand the importance of asking? I think that they're not going to lose trust. So how would you respond to that?
I would say that when in any relationships where you're building trust, whether it's, physician and patient or friends or, spouses, whatever the relationship is, trust is built on information, right? So if you feel like you have a relationship with your patient where trust has already been established, then you're not acting in faith of that trust by withholding information. I would say that if the patient trusts you, then they trust you to provide them all the information. And again, I think we have to be careful as well in looking at this as something we're trying to convince patients to do. Mm-hmm. We have to trust our patients as well, that they can make the best decisions for themselves. And so in providing all the information, it's not about trying to convince, but it's about arming patients with the information that they need to know to be empowered to make the decision for themselves. And in that way, trust can't be broken. In that way, that should create more trust. The patient knowing that they are being provided complete and comprehensive information so that they can make a decision for themselves.
That's absolutely so perfect and right on. And I think really thinking about it as from an information perspective, you're not breaking trust if it's from that perspective of I want you to have this information.
Absolutely.
Right? So thank you. That's fabulous. And we'll hopefully have time at the end to come back. I know we'll have many, many more questions. But let me introduce Fabian Robles. And I didn't say it quite right, Fabian, so you can correct me when you come on. So I just want to read a little bit about Fabian because he has such an interesting background that I think brings to his work and to this topic. Fabian grew up in Venezuela and has a solid desire to assist those in need. So at 13 years old, he began volunteering for healthcare community outreach initiatives. And eventually he joined a prestigious urban search and rescue group as a member and instructor until 2008. And then meanwhile, he was pursuing his medical degree in Central University of Venezuela. He worked as a physician in an emergency setting in Caracas, Venezuela, at the night shift as a medical supervisor for a busy emergency room. And unfortunately, due to the unstable political and economic situation in Venezuela, Fabian and his family had to make a very difficult decision and to start a new life in the United States, and left Venezuela. During his training to return to practice medicine in the US, Fabian worked in different positions within the health sector, from a nursing assistant to a home health setting to a medical interpreter for a reputable health system. Again, with a really broad range of experiences and insights. And he graduated with honors in 2020 with a Master's of Science in Healthcare Leadership and Management at UT Dallas School of Management. Fabian found the opportunity to apply for a pilot program at the Simmons Cancer Center as the first clinical trial navigator. And in this position, he was able to use the skills he learned as a physician, an interpreter, and investigator, and was able to identify barriers and biases that were detouring patients' participation in clinical trials and studies. He also promoted awareness through education among clinical care and clinical research staff. And due to this success, Fabian, congratulations, became the manager of the clinical trial navigation for the clinical research office, as we've already heard. And, really is bringing his wealth of experience and knowledge to his navigation. And he really also advocates for the rights of limited English proficient patients for adequate and reasonable quality health care. So Fabian, I'm going to turn things over to you and want to really hear about what you're doing and how you've done this at UT Southwestern. So thanks.
Thank you so much, Linda. First, I want to thank the American Cancer Society for the invitation and the opportunity to talk to you about my experience as a clinical trial navigator and the lessons we learned in expanding this program. So I started in November 2008 with a team of clinical coordinators stationed in Parkland Hospital, which Marisha explained is at our safety net hospital in Dallas area. As you all understand, most patients from the unrepresented community utilize this health system as a resource of access to healthcare, making this an excellent place to start a navigation program. While going through my onboarding process in clinical research, I observed the intricate interactions between the clinical staff and the research team. It became clear to me how overwhelming it could be for patients and their loved one to navigate this complex healthcare system, particularly when I approach and discuss a clinical trial. It is interesting while through that our community expressed the same sentiments and findings. And you might ask, how do we know? So our Office of Community Outreach has several meetings with the community. About 140 people participate in these conversations and express having these barriers when choosing a cancer center. It is important to address these concerns because if people have doubts about the quality of the care provided, they might have the similar concerns when consider participating in a clinical trial. So it's completely understandable, right? So during my time working with patients at Parkland, I discovered that there is a significant amount of fear and mistrust within the healthcare industry. And this often is due to the numerous barriers that patients face. which can cause anxiety for both patients and their loved ones. One of the main causes of their fear is the lack of reliable information about their disease and their inability to obtain their preferred language, particularly with the Spanish community, that's that one I served. The patients also presented with some limitation in accessing essential resources. For example, some patients cannot take time off work, especially when they have 2 or 3 jobs to support their families. I had patients afraid of receiving treatment because they fear being deported because they didn't have the way to pay treatment. Even in some occasions, they were afraid to come to the appointment alone for fear to not understanding the instruction from the medical team. But the real challenge that we had is to fix quickly was the misinformation in the community due to the low literacy and uneasy access to the accurate information. The same thing happened during the pandemic, where wrong information will be spread in social media as wildfire, and verified and truthful information, if any, was only given in English. So we had to get our hands dirty, and we came up with an easy to read 2-page guide where the patient could get reliable information from the center that is taking care of them, explaining the process and benefits of the clinical trial. And yes, we translate that guide to reach the Hispanic community, but we did not stop there. So we partnered with Parkland, and they reviewed and lowered their registry even more. That way we could reach even more people. And of course, we translate that information as well. So we have already found a way to inform patients in their preferred language about the process and benefits of participating in a clinical trial. But unfortunately, were other problems. So how can we create an environment for patients to feel comfortable and want to participate in a clinical study? And there's another issue to play. Do you know that patients and their families get information about clinical trials through their doctors? How can we make doctors present clinical trials as an alternative treatment for their patients? This aspect is so important for this program success, because if the patient will listen to their physician's recommendations, having an alternative on hand will help the patients and loved ones decide on the best approach. With our faculty, we began to make presentations to residents and fellows on the importance of them presenting clinical studies and their barriers, fear, and biases their patients have. But even more interesting, and you can see in the Health Information National Trend Survey, that is publication number 48, that even though only 23% of the patients who had been presented with a clinical study, only 46 say yes. So the majority of people still have no interest in participating in a clinical trial. So despite overcoming some of the barriers such as the language and education that I already mentioned, it struck me there was still resistance from patients who did not want to participate in a clinical study. So this led me to start compiling the most common reasons a patient is discouraged from participating in a clinical trial. And even though the declining rate in our cancer center was lower than the national average, there were more barriers that needed to be addressed, because the lack of interest in clinical trial was the main reason the patients were unwilling to participate. And this could be a reflection of the mistrust or misperception regarding a clinical trial, especially in the Black and African American population, as you can see in our findings. What we can do to overcome the challenge of distrust? So I think we first have to understand where the mistrust is coming from and accept that it's not a simple or an easy answer. In the patients I interact with, I saw that their distrust was a combination of fear, cultural biases, such as religious or ethnic biases, and also family dynamics. I once encountered a fascinating scenario where the authority to determine whether or not a patient could partake in a clinical study did not rest with the patient or the healthcare provider, but instead with the head of the family member, or we call patriarch. Through this experience, I learned that it is crucial to educate not only the patient, but also the families about clinical trials. This is because the families' opinions and recommendation can greatly impact the patient's decision-making process. If the patient and their family lack access to reliable information about the advantage of clinical trials, success stories, and safety protocols in research, and if this information is not presented in a language they can comprehend, they may opt out for what they perceive the best or the safest option. So I search for ways to share this information with patients and their loved ones. And in my quest, I attended a conference in Chicago, and I had a chance to speak with this patient advocate. And I'm struggling trying to recall her name of the person who shared this brilliant suggestion with me, but the idea couldn't solve my misinformation problem. So she emphasized the need to invest in our community by disseminating the information beyond the hospital premises through social media or the community or the church through events. Then this approach will enable people to learn about benefits of the clinical trial without added stress of receiving during a cancer diagnosis. So we start engaging and assisting in several events in our community and creating networks with foundations and institutions that have the same interest in providing resources to patients and families. And we're working very closely with the Office of Community Outreach, and we are in our patients advocate being involved as much as possible to spread the word and educate the population about the benefits of the clinical study. And for those of us who were unable to reach in these community events, then we have a platform where they can contact us through our cancer answer line, where they can call or send an email with for any questions related to clinical trials or any question or resources they might require from the Siemens Cancer Centers. And because we want our community from the Parkland Health System to access to this information, the Parkland Cancer Program gratefully gave us a page where their patients can access the same information in both languages, even explain the role of the research navigator or clinical trial navigator. This is the moment of truth. Are the patients and the loved one convinced to participate, and is the patient ready to sign a consent? As I mentioned in the past, a language barrier can cause issues in the relationship between the patients and the physicians. Simply using a phone or video interpreter may not be sufficient. To give you one of many examples, most phone interpreter services are not fully trained or familiar with the complex terminology used in cancer settings, much less with the language used in research. Therefore, the patients and their relatives are more confused about the treatment plan. So having a bilingual navigator or a trained in-person interpreter could help with this issue. Another game changer was having the fully translate consent form, where the patients and family members could read and relate to the explanation of the study. Again, it is important to address cultural biases and provide audiovisual materials if possible to help establish a strong connection with the patient and their family members and enable them to make informed decisions about participating in a study. Lastly, fostering positive work relationships and effective communication with the clinical nurse navigator. and social work will help patients feel secure, knowing their needs will be heard and attended to. If you're trying to develop a program like ours, or just want to improve the accruals from the minority population, let me give you some recommendations. It is important to spend quality of time with patients and their families. This includes actively listening to their concerns and fears and explaining the difference between the standard of care and clinical trials. You should also be available to answer questions and help patients' families overcome their biases or obstacles they might have to prevent them from participating. Identifying these potential barriers to participation and encouraging their thoughtful decision-making about whether or not to participate in a clinical trial study is essential. Remember to emphasize that participation in the study is entirely voluntary, and the goal is to improve patients' health and well-being. Ultimately, the patient should be empowered to decide and take the necessary time. And last, community outreach will help to suppress the misinformation or the misrepresentation of clinical trials. And so you might ask, Fabian, could you simplify even more this takeaways? So sure, I can do so for you. So in order to foster trust with our patients in our community, it is vital that we demonstrate empathy, avoid conflicts of interest, and maintain a high level of competency. And you might say, Fabian, you're so smart. You have created a formula might be the answer to solve the issue of mistrust in clinical healthcare. However, I must say that I'm not that smart. I'm just a Jon Stewart fan, and I'm quoting a Dr. Saad, a former professor at Yale that now is our new dean of School of Public Health, who had an exciting conversation in this podcast about vaccination hesitancy, where they describe some of the same issues we face with research and clinical trials. And last, as the saying goes, it takes a village to raise this program. Many people involved in this project are not listed in this slide, but are constantly helping us improve and move forward with this initiative. And some of these individuals include Dr. Magnoon from the School of Public Health, Dr. Mira, Anabel Castillo, and Rene Barber from the Office of Community Outreach, Nasser Qureshi and his research team at Parkland, and the faculty that sees patients at the Cancer Center, to name a few. I would like also to express my gratitude to Dr. David Gerber for his invaluable guidance and unwavering faith in this project. Also thanks to Dr. Sadeghi for his support and mentoring throughout this process. I extend my appreciation to Ms. Erin Williams for entrusting me with the leadership of the team, and to Amy Israel for her outstanding support in this project. I am grateful to the leadership group at Parkland for their support and allyship. Lastly, I would like to thank Helen Ruiz for being our excellent partner in crime and for always advocating for the research patients. I would like to thank you very much as well for being with us today and for sharing our common goal of providing the best healthcare to our patients. Thanks.
Oh, Fabian, thank you so much. That's so inspirational, informative. I think there's so many great takeaways for everyone who is on the call as they think about their own programs. And Maurice and Fabian, we actually have quite a few questions in the Q&A, and we have some time. So I think I will pose a couple of these to you, and either one of you can jump in depending on who wants to answer, maybe both of you. I think one question that came up was a couple people would like to have access, would like to know how to get access to your faculty and clinical training. Is that something that's available? Is it something that could be purchased? I think this is an issue we all have in terms of training our clinical staff. And wonder what your thoughts are about that.
Wow. So I will ask. We've never been asked that before. This is a fairly new program over the past couple of years, training program that we've implemented. So it hasn't been widely publicized outside of the organization, but it's certainly great to know that people are interested, and that's something that we'll think about. I'll take that back
Okay.
to the group.
Okay, I think we're all developing different tools and trying to address these, and sort of how we can share when it's the right time is just so important. And we appreciate that, because you have quite a few questions about that. I know, Fabian, did you want to add anything to that or no?
No, I was gonna say exactly what Marisa said. I was going back to Dr. Gerber, because that was in Dr. Sadeghi. That was their initiative, and it worked perfectly for us.
Oh, great. I think one of the other questions was probably, Fabian, a little bit more in your space, but when do you first connect with patients as that navigator? I think you both talked so much about the importance of outreach and kind of not waiting, right, for our education to someone has a diagnosis. And we come back to that because I think there are a couple questions related to outreach. But I was curious, Fabian, kind of from your perspective, when is that first touch from a clinical trial navigator's perspective?
So at the beginning, my first touch was when the patient was considered for a clinical trial. The physician will present or bring the option to the patient, and then they'll invite me to the meeting or the consultation. That was the first approach. Now we're trying to reach our patients even before the first consult, and not because of talking about the clinical trial itself, and in particular one, but actually creating education before the first appointment. And that's to diminish this anxiety that happens when you need to go to the first appointment, because the physician will try to explain what is standard of care and when clinical trial. So patients are overwhelmed with information at that moment. So we think it actually, if we ease that fear from the beginning before the first appointment, might help for them to approach the option of the clinical trial.
So it's almost maybe before they're even considering a clinical trial, sort of, again, just like you're doing an outreach, trying to help people start at understanding this better and being more prepared.
Correct.
Okay, that's great. Go ahead, Marisa.
I could. And just saying that, that is also, in a perfect world scenario. That's how, we envision it. Fabian and I, we envision it as, we get to the patients first, right? Before they may even be approached about a clinical trial. What we're learning in the development of this program, though, is, in our cancer center, our clinical research teams are broken up into disease-oriented teams, and no one disease-oriented team is alike, and they already have established processes. And so sometimes, it again, like Fabian said at the end of his presentation, there's no one scenario that's going to fit everyone. We have to sometimes tailor it depending on the team that we're working in, because the truth is that we are a new program. We're a new role that's coming in and getting involved in clinical trials. And so we have to do it in a way that makes sense for the patient, but we also have to implement it in a way that makes sense for the clinical research teams as well.
Yeah, I think that's a really, really important point, Marisa. And you're right. It's every team might look a little different, every disease site. I think as you're talking about that too, I think I'm curious as to sort of how sort of some of the physicians or oncologists may feel about their patients hearing more about clinical trials when they may or may not be offered a trial. Have you experienced any, in addition to training them about these issues, have you had any of that kind of conversation with your providers?
Yeah, so and at the beginning, when we started this program, we had to talk to fellows that were the first contact with the patients and explaining the clinical trial and the eligibility for those. And Dr. David Gerber, we do once a year with new fellows when they're entering in their training, we have a class where we explain by the cultural biases, patients' barriers, and also the importance of offering a clinical trial.
Okay, that's great. And I think, and again, I think as we're asking some of these questions, and again, I think as Heather said at the beginning of the call, we're really going to be having some other calls in the fall to kind of be able to dig deep, because again, there's so much to learn here in terms of even the, as you're saying, Marissa, even the operations, right, of a program like this, as well as all the training. I think another question that came up was, how do you ensure the oncology clinical trials that are available at UT Southwestern are also activated at Parkland? And boy, is that a loaded question. And that's probably a whole hour webinar in its own, but maybe just at a high level, how are you dealing with that? Because I think for many of us in multi-layered health systems, the trial may not be open everywhere, right?
There are so many factors that influence whether or not a trial gets open at Parkland. A UT Southwestern trial gets open at Parkland. And to be honest, I think it's something that we're still working towards. Not every single study at UT Southwestern is open at Parkland. It would be great if they were. But there are lots of factors involved, and sometimes it's on the part of UT Southwestern, sometimes it's on the part of Parkland and requirements they might have. Sometimes it's on the part of the sponsor and not wanting to open at Parkland. So it's kind of a mixture of things that can all affect a study being open. Well, one thing that we are doing, though, is encouraging it. The group that I mentioned earlier, the Equity in Clinical Trials Work Group, one thing that we're trying to do is develop, we have done is developed a list of resources for researchers to refer to when thinking about how to address diversity on their clinical trial. How are they going to recruit to have diversity for a specific clinical trial? And one of the things that we encourage them to do in this list of resources is consider opening it at Parkland. All we can do is encourage that and support it. But again, there are many factors at play with that as well.
So one of the things, that's where we got the grant of the Stand Up for Cancer, is to show that you should be able to open these trials in Parkland, or willing to, because you're going to provide some services to the unrepresented.
Mm-hmm. And there may be ways, I think you're addressing, I think others are, are there ways to transport someone between the two sites? And so how do you build those services around them? So Heather, I think we're getting close to the time. I don't know if we have time for one more question or not. I know we have a few things to wrap up. So, okay. So I think just for everyone to know too, we've gotten a great list of questions here. And I know that Heather and her team are going to be looking at those questions to help map out what are some of the next steps in terms of the fall series. So Heather, I'll turn it back over to you. And both, thank you, Marissa. And I mean, this was fabulous. Thank you for sharing all your learnings.
Yes, thank you. I want to just echo, this was just a fabulous presentation. And there are so many comments in the chat, just shouting your praises and with lots of follow-up questions. And I am very excited to add, we will send out an invitation to a follow-up session so that we can address all these deep dive questions and really pass on some more information. So stay tuned for an invitation to a session in September. I want to express my gratitude again to our presenters and our panelists today. It's fantastic. I'd also like to say thank you again to our sponsors for making this possible. And there will be a survey that will come along with your recording. So we did also get lots of questions about the recording. You will get a recording. It will come with the evaluation. We really encourage you to fill out the evaluation. We're using that to plan future sessions, and it will only take a moment. So thank you very much for joining us today, and we will see you again in the fall. Thank you very much.
Thank you.